Hello students, welcome back to my channel. So we are studying gastrointestinal system from the first aid now, and today we are going to discuss the pathologies first. So let's talk about the oral pathologies. So aphthous ulcers, squamous cell carcinoma, sialolithiasis, sialidinitis, salivary gland tumors, these are some of the oral pathologies that are present in the oral cavity. So aphthous ulcer is also known as canker sores, and they are common oral lesions that appear as painful ulcers. And you need to remember that there are recurrent aphthous ulcers are seen in some diseases such as the celiac disease, SLE, IBD, as well as in the Behçet syndrome and HIV infection. Squamous cell carcinoma is the most common malignancy of the oral cavity, which usually occur in the tongue, and erythroplakia, leukoplakia are the precursors. Stone formation occurs at the duct of the major salivary glands, and it is associated with dehydration and trauma mostly. And sialidinitis is actually the inflammation, and that is due to the obstruction or due to the infections. If we talk about the salivary gland tumors, then the parotid is usually the tumors in the parotid glands. They are usually benign. You can remember by the mnemonic, parotid is very polite, whereas the tumor in submandibular and sublingual glands and minor salivary glands are usually malignant. They are typically painless, but if there is a facial paralysis or there is pain, it suggests the malignant involvement. So the next thing is the pleomorphic adenoma, and the next thing is the Warthin tumor and the mesoepidermoid carcinoma. So the pleomorphic adenoma is actually the benign tumor, benign mixed tumor, which is the most common one, and is composed of the stroma, the chondromyxoid stroma and epithelium, and reoccur if it is incompletely excised or ruptured intraoperatively. So mnemonic to remember the pleomorphic adenoma is please remove properly, but otherwise it will remain and it will reoccur, and it can also has a potential for changing into the malignant tumor. Warthin tumor, the mnemonic for the Warthin tumor is various from Germany loves smoking. So the Warthin tumors is a benign cystic tumor with germinal centers. They may be bilateral or multifocal, and they are typically found in people who smoke. Mucoepidermoid carcinoma is the most common malignant tumor, the mucoepidermoid carcinoma, whereas the mucocutaneous and squamous component are present in this type of carcinomas. The most common malignant tumor is a mucoepidermoid carcinoma, and the most common benign tumor or the most common salivary tumor is a pleomorphic adenoma. Now let's move on to the next pathology of the oral cavity, that is the achalasia. So achalasia is not of the oral cavity but of the esophagus. So you can remember the A can't relax, so the lower esophageal sphincter can't relax, and it due to the degeneration of the inhibitory neurons, that is the nitric oxide and the VIP. So there is no go, that means no peristalsis, and it is due to these inhibitory neurons are present in the myenteric plexus of the esophageal wall. The causes can be divided into primary cause and the secondary cause. The primary cause is usually idiopathic, and the secondary causes is due secondary to the infections such as the Chagas disease and some extraesophageal malignancies. Then in the achalasia, the dysphagia is usually progressive to solids and liquids, unlike obstruction, which is primarily solids, for example in the tumors. Then it is associated with increased risk of cancers. So that is one complication of achalasias. So they are the best definitive diagnosis with a manometry that involve finding include uncoordinated absent paracelsus with increased lower esophageal resting pressure. Barium swallow shows dilated esophagus with area of distal stenosis, and chest x-ray show the air fluid levels. And the treatment usually surgical endoscopic procedures such as toxin injections. So this was about the achalasia. So now let's move on to the next pathologies. So there are some other esophageal pathologies as well. That is the GERD. Then we have the esophagitis, and then we have the esophageal strictures, Plummer-Vinson syndrome, Mail-Rowitz syndrome, varices, distal esophageal spasm, scleroderma, and esophageal perforation. So GERD and Plummer-Vinson syndrome is most important here. So we talk about the GERD. So GERD is actually a decrease in the lower esophageal tone. It is commonly present as the heartburn, irritation, or dysphagia. It may also present as chronic cough or hoarseness. This associated with asthma, and complication may include the strictures, bad esophagus, and esophagitis. Plummer-Vinson syndrome, remember the mnemonic Plummer dies, Plummer G dies. So G is for the glossitis, and D is for the dysphagia, I is for the iron deficiency anemia, and E is for the esophageal webs, and S is for the squamous cell carcinoma. So these are the two most important. Otherwise, you need to remember the esophagitis, that is secondary to infections. Usually it's one type of esophagitis that could be due to the food allergens. Then we have strictures that could be due to the acid reflux, and Mallory-Weiss syndrome, and double L is for the longitudinal lacerations that can occur due to severe vomiting. Then we have the Bohoff syndrome, that is the distal esophageal rupture, that is a transmural, like the Mallory-Weiss syndrome, which is longitudinal lacerations, and that is just present in the submucosa. We have varices that we will talk in more details when we are going to discuss about the liver. Distal esophageal spasm is also known as the diffuse esophageal spasm, and the tone is normal, and the shape of the esophagus is corkscrew under the barium swallow, and manometry is diagnostics. Then we have the scleroderma, that is a dysphagia is also the component of the crest syndrome of the scleroderma. Esophageal perforation is most commonly iatrogenic, secondary to the instrumentation. Bohoff syndrome is actually the transmural, usually distal esophageal rupture due to the violent retching. So Bohoff syndrome and Mallory-Weiss syndrome. So the Mallory-Weiss syndrome is actually just the submucosa is affected, not the whole layer. So if we talk about the Barrett esophagus, so Barrett esophagus is actually the metaplasia, that is replacement of the non-keratinized stratified epithelium with intestinal epithelium, and in the distal esophagus, and that is due to the GERD and associated with increased risk of esophageal adenocarcinomas. So it is actually it can occur due to the GERD, and it can cause the esophageal adenocarcinoma. So there are two types of cancers, esophageal cancers, the squamous cell carcinoma and adenocarcinoma. So adenocarcinomas, the risk factors are the chronic GERD and the bad esophagus, and obesity and tobacco smoking, where the squamous cell carcinoma is alcohol is the most common one, hot liquids, strictures, smoking, and achalasia. Upper 2/3 is affected by the squamous cell carcinomas, and lower 1/3 can be affected by the adenocarcinoma. And squamous cell carcinoma is usually common worldwide, whereas in America the adenocarcinoma is the most common one. So we talk about the esophageal cancer that typically present with a progressive dysphagia, that is it occurs first with the solids and then with the liquids, and then we have weight loss as well, and the course is very aggressive. It is a very poor prognosis because lack of serosa allowing the rapid extension. So this is that is why there is a poor prognosis due to the advanced disease as a presentation. So this was all about some of the pathologies about the GIT system. We are going to talk about more pathologies in the next video. Thank you for watching. Don't forget to subscribe and like this video.